Okay. I guess we're recording now. Sally puts the ball in the basket, not terribly complex. Sally then goes away. Anne, who's just kind of been sitting there like a doll, basically, while Sally goes away, takes the ball out of the basket and puts it in the box. And then she sits down again, and in walks Sally again. And the question I have for you is, where will Sally look for the ball? Well, I've got a non-autistic answer from Daniel in the basket, who thinks that she might look for the ball in the box. Well, the odds are then that we have no autistic people in the audience, because when somebody has autism, one of the thoughts is that they can't see the world through anybody else's eyes but their own, because they think everybody is just an extension of them. They haven't really developed that theory of the mind yet, where somebody is different than them. And so somebody else won't see something different than they see. And also that somebody else can't help them, other than the fact that somebody else will be kind of a tool for them to kind of get what they want. Hopefully, these will advance. I won't walk around as much as I like to. So I'll start out with a disclaimer then, that autism is really poorly understood. And because it's so poorly understood, some of the comments that I'm going to be making are kind of my opinion more than clearly literature based. And I'll try to do my best as we go through this to try to separate the two of them. Well, to begin with, let's define autism. I guess the best way to say, does everybody here know what the DSM is? Anybody not know what the DSM is? Raise your hand if you don't. Okay, we've got a couple of people who aren't lying. So the Diagnostic and Statistical Manual of Mental Illness is from the American Psychiatric Association's professional reference book on mental health and brain-related conditions. The most current edition is the DSM-5. And it's the main guide that we use to help us define different mental health and developmental conditions. So what's it used for? The first step in treating pretty much any health condition, whether it's physical or mental, is actually diagnosing the condition. That's where the DSM-5 comes in, and it provides clear, highly detailed definitions of these kind of neuropsychiatric issues. It also provides details and examples of the signs and symptoms of these conditions. It also organizes them into groups, and that makes it easier for healthcare providers to accurately diagnose those conditions and tell them apart from other conditions with similar signs and symptoms. So what is autism? Well, this is a pretty important question if we're talking about autism, to know what we're talking about. This is now a condition that, according to the CDC, this year says affects about 1 in 36 kids, 8-year-olds, which is nearly 3%. If I can have a show of hands of people who have had any interaction or know anybody with autism. So we're probably up around 90%. Well, according to the DSM-4, which was the previous edition of this Diagnostic and Statistical Manual, autism was one of 5 pervasive developmental disorders. It was autism, Asperger's syndrome, pervasive developmental disorder not otherwise specified, or NOS, childhood disintegrative order, and Rett syndrome. DSM-5 came along and changed that into a single diagnostic category. Dropped childhood disintegrative disorder, essentially, made Rett syndrome completely separate, and basically put together autism, Asperger's, and pervasive developmental disorder not otherwise specified. How many of you know somebody with Asperger's syndrome? You don't know anybody with Asperger's syndrome because it doesn't exist anymore. We just got rid of it. Asperger's syndrome is now pretty much combined into this gemisch in the DSM-5 of autism. We want to be more confusing about it. If somebody has some of the language difficulties, but not the stereotypies of autism, they can have what the DSM-5 is now calling the social pragmatic language disorder, which everybody thought was going to be really neat 10 years ago or so when it came out, but none of us hardly ever use it diagnostically. So what is autism now, according to the DSM-5? Now we're going to try to define it. To meet the diagnostic criteria, the child has to have persistent deficits in 3 areas of social communication and interaction. That's one thing. Plus, they need to have at least 2 of 4 types of restrictive and repetitive behaviors. So what are those social and communication disorders? Well, they're persistent deficits in social communication and social interactions. And the kids have to meet all 3 of these criteria. And the 3 criteria basically are that these are kids who can't do well in back and forth conversations. They don't share interests well. The second thing is they're poor with nonverbal interactions. So they really don't do a great job with eye contact. They generally have language delays, anything from very concrete type language to being completely nonverbal. And then the third area is deficits in maintaining and understanding relationships. So these are kids that when everybody else is talking about how far Creighton's going to go in the NCAA tournament, and all the other 6 kids are standing around saying, oh, I think that they'll get out, they'll get to the Sweet 16, maybe the Elite 8. The autistic kid is kind of saying, well, what do you think about dinosaurs, though? Don't you think that Tyrannosaurus Rex is the most important thing? And they can't get off of dinosaurs. So they have trouble understanding these interpersonal relationships. And with that, then, they have trouble with imaginative play because they can't think of anything outside of themselves. And they'll also not really have a lot of interest in what their peers are thinking about. The restrictive and repetitive behavior patterns, the kids have to have 2 or 4 of these. Either they have to have stereotypic or repetitive movements. So these are the kids who have echolalia. They're repeating things over and over again. They're lining up toys. And if you, God forbid, you take one of these toys away from them, they decompensate. They have trouble changing routines. So if mom takes them to Target on the same route every other day to get stuff, and she changes the route, the kids decompensate because this isn't the way I know it's supposed to be. This is a new way to get there. They have highly restricted and fixed interests. And that's kind of what we're talking about too with this communication with others, where they really perseverate on one thing. They'll perseverate on dinosaurs. They'll perseverate on a special cartoon. They'll perseverate on geology, some really bizarre things that we hear about. And that they can be really hyper or hyposensitive to things. They might learn to explore things by licking them. Some of these kids can really be bothered by the tags on their shirts because it just bothers. So they're very sensitive to touch, very sensitive to loud noises. They live in a house right off Dodge Street, and whenever a truck goes by, it drives them crazy. One of the questions we ask is, how much does the vacuum bother? So that's what it is. I'm not crazy about the DSM-5. And the reason for that is there's a lot of a checklist part of it, what we've just gone over. 1, 2, 3 for communication, 1 of 4 for these restrictive and repetitive behaviors. I like to think of the core issue, in my opinion, the core issue in autism being that the kids really don't see the world outside of themselves. All of these other things that we talk about, the communication, it's hard for them to think about communicating with somebody else because they don't understand somebody else. And then I think a lot of these restrictive and repetitive behaviors are the way the kids respond to a world that is just overwhelming them with information. So don't tell me anything more about all these other things. I'm going to just think about what I love, Tyrannosaurus Rex. A couple of other things that we need to know about autism, according to DSM-5, is that these have to be presented early. It doesn't all of a sudden show up, somebody's fine, and then at 18, they become autistic. They have to be clinically significant. A lot of little kids line up toys. The kids with autism, when they line up the toys, if you pick one up, they can really decompensate. And some of these behaviors are, because we want to think back to something like theory of the mind, some of these behaviors are appropriate for a 6-month-old. 6-month-olds, the world revolves around them. I don't know if any of you have kids or if you have siblings or you have nieces or nephews, but when a kid is 6 or 7 months old, all they see is themselves and everybody else is an extension of them. And so if somebody has significant intellectual disability, it's hard to make an autism diagnosis sometimes because the kids need to have a cognitive development or a developmental level of probably about 15 to 18 months before you can really start to tease out some of these things as being much different than what a younger kid would do, or what a kid with significant intellectual disability would do if his developmental age is around a year. And in fact, the MCHAT, modified checklist for autism in toddlers, which is one of the things that we use in little kids, isn't really valid in kids less than 15 to 18 months, because kids 15 to 18 months do a lot of these things that are on the list to make the diagnosis. So what is autism? It's an individual who's always had difficulty with social interactions, even to the extent of being nonverbal, who has some unusual restrictive behaviors and interests, which may cause difficulty with interactions with the environment or with other people. And in reality, it is so diverse in its presentation that those of us who see a lot of kids with autism say that if you've seen one kid with autism, guess what? You've seen one kid with autism. You might remember years ago, there was a movie with Dustin Hoffman, Rain Man. And Rain Man was one of the early presentations to the public of somebody who had autism. Well, that was great. But that's mild because we also see kids who look like they're schizophrenic from an old time movie, sitting in the corner, not interacting with anybody, completely nonverbal. That's the spectrum that we see of autism spectrum disorder. So if you've seen one, you've seen one. And so the DSM-5 now has specifiers. And the specifiers in the DSM-5 talk about, all right, we've talked about these three areas of social communication that the kids have to have deficits in. We've talked about 2 of 4 areas of restrictive and repetitive behavior that the kids have to have deficits in. What do we do with that? Well, according to the DSM-5, we then have specifiers. And the specifiers talk about the severity of how much support the kids need. Level 1, 2, and 3. Level 1, they don't have real significant needs. They need some help to kind of get along, but they can live on their own, basically. Level 3, without support, the deficits result in severe impairment across all contexts and spheres of functioning. Because I'm a pediatrician, and a pediatrician who's primarily interested in very young kids, I think this is, disclaimer, my bias, kind of nonsense. Why do I think it's kind of nonsense? Because if you get level 1 without support, deficits cause impairment, anybody here have a lot of, or have much interaction with any 3-year-olds? Raise your hand if you have any interaction with 3-year-olds. Okay, so 25% of you. Of those who raised your hand, for the 3-year-old that you're aware of, how well do they get along in the world without support? Do they make their own peanut butter and jelly sandwich? Can they always go to the bathroom on their own? Can they balance a checkbook? So, I mean, so give me a break. Well, one of the things that we're trying to do is diagnose autism earlier and earlier. And if we're going to be diagnosing it earlier and earlier, as early as really 18 to 24 months generally would be our goal, this doesn't make a whole heck of a lot of sense to me. It really makes much more sense if we're talking about kids, talking about adolescents and things like that, trying to plan for where they're going to go, because this is a lifelong condition, plans of where they're going to go after school, for example. Are they going to be able to live on their own? Are they going to need to be in a group home, or where they're going to be? What causes autism? Bruno Bettelheim, back in probably the 30s or the 40s, I think, posited that it was caused by cold and non-reassuring mothers. If all you females in here, it's all your fault, is basically what he would say. These kids never had a loving mother who gave them attention, and that was the cause of their autism. They never understood what love was, so they never understood what somebody else loving them meant, basically. That's not what causes autism. Anybody heard of Andrew Wakefield? Andrew Wakefield is a physician, I think, in England in the 1990s, who said that the MMR was the measles, mumps, and rubella vaccine was the cause of autism. That's not the cause of autism, but this lady is saying, listen to Andrew Wakefield. His data was completely proven as inaccurate, but he really started a whole movement that to this day, I frequently hear parents say, I don't want my kid vaccinated because I'm afraid it's going to give him autism. Cause of autism is unknown, but we do know one thing about autism. Autism has caused more episodes of measles, mumps, and rubella than anything else. And the reason for that is because parents have become so afraid of immunizations that the rate of immunizations has gone down significantly. And what that's done is caused us to see more measles, mumps, and rubella. Autism as an entity, however, does not cause, immunizations do not cause autism. There is no good evidence for that. Autism was described first in 1943 by Kanner, who was a psychologist at Johns Hopkins, who described 11 kids who preferred social isolation and indifference to others. These kids have little eye contact or imaginary play. Hey, it sounds like what we're talking about in the DSM-5, and seem to live in their own world. So what really causes autism? The real answer is we really don't know, okay? There's no single etiology. It's clear that some cases are associated with certain syndromes that most of us have heard about, and that there are cases that are considered idiopathic. The syndromic autism, autism which is associated with certain syndromes, is probably found in about 10 to 15% of the cases. Non-syndromic cases are a mixed group, which almost certainly have a genetic component and perhaps environmental mediators, not caused by Bettelheim's cold and unnurturing parents. So if we want to be honest, we really don't know what causes autism. It's multifactorial. And my bias about autism is that it is basically a behavioral phenotype, often associated with other conditions. So basically, it describes a behavior. Nothing more, nothing less than that. So while there's many cases that are non-syndromic, others are syndromic and found as a not uncommon behavioral phenotype in some known medical conditions. For example, Fragile X syndrome, if you've heard of that, trisomy 21, fetal alcohol syndrome, and some of the neurocutaneous syndromes like tuberous sclerosis or neurofibromatosis. There's a list of some of the conditions which are associated with autistic behavior. So most of us know of somebody or have watched TV and seen kids with trisomy 21. Most of us, when we think of trisomy 21, think of kids with some intellectual disability, but who are warm and loving and hugging and just great. But if you look at the whole population of kids with trisomy 21, probably around 10% of them meet the criteria for autism. Little girl with trisomy 21 and another little girl with fetal alcohol syndrome. It's just kind of a fun slide. Neuropathologic correlates. There are no consistent MRI pathology findings in idiopathic autism. Although some of the kids could have a normal head circumference at birth, although there was other data that said kids had bigger head circumference at birth. They had increased whole brain volumes by 5 to 16 years of age. The whole brain volume was less than control. 2 to 3 years, there was increased cerebral white matter and gray matter, and the cerebellar gray matter decreased. The amygdala volume was also reportedly increased. None of this is definitively borne out. MRIs don't really tell you, hey, he has autism. How do you diagnose it? Well, the American Academy of Pediatrics recommends that all children be screened specifically for autism during well-child checks at 18 months and 24 months. And I mentioned the MCHAT-R earlier. It's probably the one most commonly used by pediatricians, and it's 20 questions. And basically, when you look at those 20 questions, it asks about things like primarily what we call joint attention, which is what happens with as children develop this theory of the mind. Joint attention is good eye contact. It's what we call proto-imperative and proto-declarative pointing. So it's not just pointing at something, but when kids who don't have autism want mom to see what they're seeing, it's called proto-declarative pointing. What they'll do is they'll point, but that's not where it stops, because then they'll look at mom and then look back at the thing. And what they're saying foundationally for communication is, hey, mom, look at what I'm looking at. They're not just pointing at it, but they're connecting with mom. Preceding this kind of proto-imperative, proto-declarative pointing is something we call proto-imperative pointing, which happens at about 14 months or so of age. And this means that when the kid wants his milk, which is on the table, he doesn't just go, What he does is he points. Again, he looks at mom, then he looks up at his milk. And what he's saying is, hey, mom, give me my darn milk. Different than just taking mom's hand and going, because that is for the kid who has not developed theory of the mind. That's using mom as a tool, as an extension of himself to get the milk. It might as well be a mechanical hand reaching for the milk. How do we diagnose it beyond something like the MCHAT? There's multiple questionnaires, and the questionnaires really are all based on the DSM-5. They're asking questions, asking parents or providers to really objectify those lists within the DSM-5 into what we would call a lighter scale. If you remember what a lighter scale is, never, occasionally, sometimes, always. Put your money where your mouth is, mom. How significant is this issue? Autism Diagnostic Observation Survey, the ADOS, is really used as the gold standard today. And that's a kind of one-on-one thing with the kids, where there are some standardized environments that the kids are placed in, where they're asked to read a book, to look at a book. And basically, again, the tester rates the kid as whether or not he's doing it appropriately, or whether or not he's doing it more as we would expect somebody with autism to do it. There are no lab tests or radiographic studies that can diagnose autism. It is a clinical diagnosis dependent upon the clinician's determination of whether or not the child meets those criteria as defined in the DSM-5. Physician, when looking at somebody with a probable autism diagnosis, needs to make sure that it's not a hearing issue, so the kid needs a formal audiologic evaluation. The American Academy of Pediatrics recommends Fragile X testing. Fragile X is a not uncommon condition. About 5% or so, the old literature would say, of kids with autism have Fragile X, and about 20 to 25% of kids with Fragile X have autism. The AAP, American Academy of Pediatrics, recommends a microarray, a genetic microarray, which kind of looks at duplications and deletions, although now whole exome testing is becoming cheap enough that a lot of the geneticists are recommending whole exome testing as opposed to the microarray. If there's regression, then metabolic screening and looking for Rett syndrome is recommended. Rett syndrome was one of those 5 pervasive developmental disorders, which is associated with essentially normal development until the kids are about age 2. And then there's a deceleration of head growth, so they develop microcephaly and they lose their, and there's a loss of milestones. Because so many of the kids with autism do a lot of mouthing of things because they like, one of the ways they learn about their environment is by tasting it, especially for those kids with intellectual disability. I'll usually want to check a lead level, even beyond when the AAP recommends they should do it. Because if they live, for example, in Omaha, in one of those high-risk lead areas along the river, basically, we need to make sure that they're not putting dirt in their mouth. Their lead levels. MRIs are only used to address specific findings. We don't order them routinely on kids, but if there's significant microcephaly, significant macrocephaly, asymmetric signs in their exam, then you get an MRI. Otherwise, you really don't need it. How do we treat it? Time for lunch, it looks like. You know, I'm trying to zip through this. Children with autism need to have an educational program that supports their needs. The program should strive to encourage their strengths and ameliorate their weaknesses. Now, many of them will have significant enough behavioral dysfunction that it will interfere with their ability to learn. These children then will benefit usually from additional behavioral services, and the gold standard behavioral services for kids with autism is ABA, Applied Behavioral Analysis. Applied Behavioral Analysis looks at the ABCs of a behavior, the antecedent to the behavior itself, and the consequences of the behavior. And what ABA does is it looks at the behavior that we want to change, either increase or decrease, and looks at why the kid might be doing it, looking at that antecedent, and then looking at the consequences that the kid gets from doing what he does. Because remember, a lot of these kids are frustrated because they're getting too much information from a world that they don't understand, or they have such limited ability to communicate that they can't ask for what they need. And so ABA figures that out through what's called a functional analysis of behavior, or functional behavioral analysis. And in doing that, then, it figures out what kind of consequences we can give the kids, either increase the behavior that we want, saying hi, or waving hi, or decreasing a behavior that we don't want. A tantrum when the kid isn't getting what he wants and it's inappropriate and then he's hitting or biting mom. Finally, for the pharmacist, some will require psychopharmacologic intervention to help diminish the characteristics which impede learning. One of the things to remember about autism, that in almost all cases, the medication treats symptoms of autism, things that we're seeing, an effect of the underlying disability, and not the core symptoms. There was some literature some years ago that talked about risperidone having some effect on the core symptoms of autism, but by and large, in 99% of the cases, when I'm prescribing a medication for autism, when any developmental pediatrician or pediatrician is prescribing a medication for autism, he or she is prescribing it to ameliorate a symptom that is interfering with the ability of the special education teacher to teach the kids to communicate better. what is a special education teacher doing, basically? If you look at the history of, for example, early intervention, back in 1975, there was the Education of All Handicapped Children's Act, which talked about kids getting a free and appropriate public education from ages 5 to 21 in terms of an individualized education plan. How many folks here know what have heard of IEPs? Basically, it's federally mandated that states provide educational support for kids who have significant delays. And let's look at autism as a significant delay in the sphere of development. In the same way that somebody with cerebral palsy can have a significant delay in motor skills, somebody with autism has a significant delay in social development. There have been a lot of changes and additions to the 1975 idea all the way down to 2004, where there's been the most recent recent redefinition of the Individuals with Disabilities Education Act. And it says that if we look at Part B and C, that all kids from ages 3 to 21 should get a free and appropriate public education in a least restrictive environment. So that means that kids with autism can't be put away in some kind of institution anymore. The educational system, OPS, Millard, Westside, can't move these kids out to some other place and institutionalize them. They're mandated to try to provide a education in a least restrictive environment. Now, some of these kids, their behavior can be bad enough that they can be in special rooms, ideally maybe getting to be in with other kids during lunchtime, during recess and things like that. Or if the kid's behavior is significant enough, there can be a special school for the kids, but the school needs to make every attempt to have the kids in a general education class as much as possible, general education environment. And in Part C, for those kids who are deemed at risk, 0 to 3, they're to get a free and appropriate public education with an IFSP. Who's heard of an IFSP? An IFSP is an individualized family service plan. And so with an IFSP, the family is the therapist, and the occupational therapist, the physical therapist, the speech and language pathologist is the consultant, and they'll come out to the house once or twice a month and give the parents or the primary caretakers suggestions about how to get the kid to communicate better, how to get him to more readily use a spoon and fork. And then come back in 2 weeks and say, hey, did my suggestion about when he points at something, having you give him the choice of one of two things and making him choose between the two, kind of trying to get more of that proto-imperative pointing, did that work? And mom says, not in the least. Okay, then let's try this. So autism intervention, I like to look at as a pyramid. All kids at the base of the pyramid require educational services. Facilitate those educational services because behavioral dysfunction is a significant issue with many of these kids. Some of the kids will require behavioral interventions. Maybe they'll require this ABA that I talked about. Sometimes even that doesn't work. And if that's the case, some of the kids will require psychopharmacologic intervention. And again, it's all to get back to the bottom of the pyramid so that the kids can get those educational services that they need to ameliorate some of those difficulties, which are the definition of autism, difficulty with social interaction and trying to ameliorate some of those repetitive and restrictive behaviors. So those are the three things. And a referral for educational services, what's called a multidisciplinary team assessment, to create an IEP, or for the little kids, an IFSP, I consider mandatory. And so again, birth to 3, we get early intervention. 3 to 5 is actually kind of early childhood special education preschools. 5 to 21 is in the schools. Again, ABA, applied behavior analysis, which I talked about a little bit briefly, is the gold standard. And it grew out of some work by Albert Lovas in the 1970s. And if you've seen pictures of ABA, it can be anything from having the kid sit across the table from you and saying to the kid, wave, he doesn't wave, wave, he doesn't wave, wave, he starts to wave. Now that he starts to wave, if a really good motivator for him is an M&M, you give him a pat on the back and an M&M. You keep doing that. And eventually he knows, hey, whenever I wave a little bit, I get an M&M. And eventually, even that pat on the back will be enough of a motivator for him. And so it's really breaking up some more complex tasks into their individual parts. You can also have ABA in a more naturalistic environment where you have a behavioral analyst with the kids on the playground or something like that. Again, trying to reinforce those positive behaviors and diminish those negative behaviors. Like sort of social skills training, and I just put this in because it's something that's become very popular, but there's not a lot of it around for kids with autism, because what it's doing is it's trying to teach the kids in small programs how to deal appropriately with other kids. And the drugs. The most common drugs are the atypical neuroleptics, alpha-adrenergic stimulants, the SSRIs, and primarily the whole world is on melatonin. What I need my pharmacist to help me with is that a lot of these kids won't swallow or hate medicine. And so, okay, well, put a patch on them. Well, they hate, remember, they're hypersensitive to touch and things. So you put a patch on them and they rip it off really quickly. A lot of the kids like gummy bears. We look at medications that are available in liquids. Those are usually more successful. So the pharmacotherapy addresses the aggressive behavior and the irritability, hyperactivity and inattention. In the old DSM-4, you couldn't have both ADHD and autism. Now with the DSM-5, you can, and we commonly have these kids on stimulants. We try medicines for repetitive and stereotypic behaviors. None of them seem to work, and for sleep. Aggressive behavior, more than 50% of the children with autism show it. It's a leading cause of hospitalization and institutionalization, and it worsens the prognosis and results in a lot of caregiver strain. For the irritability and aggression, Risperdal is probably, risperidone and aripiprazole are probably the main medications. Risperdal, I think risperidone is probably a little bit more effective, more weight issues with aripiprazole than with, risperidone than aripiprazole. Stabilizers like Depakote, some people really like them. There's really no good data that's consistently shown that in spite of the irritability that a lot of these kids have, that the mood stabilizers really help very much. I see a fair number of kids that come to me from other providers who have been on things like Depakote, and invariably the parents say it hasn't helped at all. Again, Lots of these kids are on stimulants or the alpha-adrenergics for their hyperactivity and their impulsivity. Works sometimes, doesn't work other times. My bias is that bias disclaimer is that the type of hyperactivity and impulsivity that we see in these kids probably has a different biologic substrate and behavioral substrate than those kids with kind of run-of-the-mill ADHD. Repetitive and stereotypic behaviors look a lot like OCD to a lot of people, obsessive compulsive disorder. Frankly, the SSRIs are not terribly good for the treatment of the repetitive behaviors in kids with autism. Again, I think because there's a different behavioral substrate for those repetitive behaviors than we see in adults and kids with obsessive compulsive disorders. Lots of comorbid conditions with autism, tic disorders, seizures, ADHD, affective disorders, GI problems, sleep disturbances, and challenging behaviors. And these are the things that make it more difficult for the teachers to teach the kids, and the things that the health professionals are often asked to address so that we can get down to the bottom of that pyramid. Lots of complementary medicine. I hope if we've kind of realized anything that we don't know a heck of a lot about definitive diagnosis and treatment in autism. And when you have a lifelong disability like autism, any parent is going to do whatever they can to help their kids. And they'll try all sorts of different things. Some of it, like melatonin to help sleep, there's good support for. Secretin was felt to help in the past, doesn't help. But we also need to really make sure that we avoid those with serious side effects like chelation. Those prescribing medicines, what we say is start low and go slow, because these kids are often more sensitive to lower doses and more sensitive to the side effects that we see with psychopharmacologic intervention. Prognostic indicators for autism, the presence of communicative speech by age 5 and an overall cognitive ability that's within the range of normal, usually is a good prognostic indicator that the kids will be able to go to kindergarten and with an IEP reasonably well. I love this. I think it's a great poster. I invite everybody to eat quickly. And I'm done, but I'd be happy to hang around and answer any questions.
Thank you, Dr. Needelman. Yeah, please come down and grab food. Are there any questions from students here before I get into Zoom and Excel questions?
Yeah. Don't worry about it. Around age 3 to 4 is kind of when we start looking at it. But the thing that we need to remember is that communication isn't just speech. And so today, a lot of the times what we'll do for many of the kids who have a significant expressive speech delay, the use of augmentative communication, iPads and things like that, is really very, very effective. And so what we want to do is understand that it takes a long time to develop speech. And so allow the kids time to develop that and not get frustrated. So to prevent that frustration, if we give them something like an augmentative device, everybody can calm down a little bit. But usually, you know, if by 4 or so, we're really not seeing any functional speech, we're usually not going to see very much.
As pharmacists, we deal a lot with vaccinations and immunizations and stuff like that. What do you think is the best, a good way to counteract people's fears about their children getting autism from getting a regular old vaccine?
Data is clear, and I think that there are some pediatricians, for example, who, if Mrs. Smith won't give her child an immunization, they say, "Don't come to me anymore. I don't want you in my office." And it's understandable. In the pediatrician's office, there might be all sorts of kids who are immunocompromised, who are on chemotherapy and things like that. And on a one-time visit for a pharmacist, it's kind of hard. There's a couple of pediatricians who I really like in Omaha, who give the parent, who kind of try to develop a relationship with the parents and kind of carry them along, basically, and continue to bring it up, not call them crazy, understanding that they want the best for their kids. But again, over time, teaching them that, the risks of not getting the immunization are much greater than the risks any of the side effects that we see with immunization. I mean, if you just look at, some of the nonsense that people have talked about for the COVID vaccines, the risk of getting COVID, should everybody in this room get a COVID vaccine because, God forbid, it increases your risk of getting a myocarditis a bit, not a severe myocarditis, but a mild myocarditis. Well, if you look at that risk compared to the risk of a myocarditis associated with true COVID, go with the shot, basically. And so I think the best way to deal with it is kind of with patience with the family and to deal with them over time. I think, frankly, having met a lot of parents who have refused immunizations, I think in a one-time visit, which is often what you're going to get, in the pharmacy world, you're not going to be able to successfully change that. I mean, these parents they believe it, and they love their kids.
It's another class coming, so I want to be respectful of everyone's time. But thank you guys for coming. I really appreciate it. Let's give Dr. Needelman another applause.
Wait. Sure. Give me just a minute.